Welcome to Hearing Hooves and Finding Zebras, updates in spontaneous coronary artery dissection. I'm Dr. Sheila Sahni, an interventional cardiologist in New Jersey and the director of the Women's Heart Program at Sahni Heart Center. And I'm honored to give you this very important lecture today. I have no financial disclosures and the session is accredited. We have a number of ongoing challenges in SCAD. Making the correct diagnosis is still a challenge. It's highly under-recognized. And unlike much of everything else in our field of cardiology, randomized controlled high-quality evidence is lacking. Much of the data that guides the diagnosis and management remains retrospective and observational, which is heavily confounded by selection, survival, and reporting bias. My goals for you in this lecture are for you to understand the recent evidence that's emerged regarding the pathophysiology of SCAD. I want to provide insight as an interventionalist of how you can recognize SCAD in the cath lab, because making the correct diagnosis is key. And I'm going to provide an overview regarding the acute management and also what you should be aware of in terms of reoccurrence. I'd also like to begin with an overview because I feel like SCAD has a very esoteric quality in science and in cardiology. I mean, the session is called Hearing Hooves and Finding Zebras. So keep these key points with you throughout the journey of the lecture. Remember that SCAD is a very high cause of under-recognition in women who present with acute myocardial infarction. It's non-atherosclerotic, it's non-traumatic, and it's non-iatrogenic in its cause of acute coronary syndrome. And that's because the coronary occlusion occurs by way of an intimal tear and an intramural hematoma development. It's that hematoma that causes compression. The management is largely conservative when the patient is stable, and you'll see why. And PCI carries a lot of technical failure and is heavily married to complications in the cath lab. Remember that the use of intracoronary imaging, as you'll see in this presentation, has led to a lot of understanding about the disease process, but it's largely reserved for cases that are ambiguous. The majority of cases are actually diagnosed with angiography and don't need any further studies. And a key association that's emerged with SCAD is the recognition that it's been associated with other arteriopathies, most important of which is fibromuscular dysplasia. In terms of prevalence of SCAD, it's really important to recognize that we just don't have accurate data in terms of epidemiology because SCAD is underreported when it's not diagnosed. And therefore, we can only understand what we know from retrospective reviews, which have shown that SCAD is a cause of acute coronary syndrome anywhere from 1% to 4%. Additionally, in women under the age of 50, it's been identified as a cause of MI 30% of the time. So keep that in mind. In terms of pathophysiology of SCAD, I've already kind of given you the punchline that this is a non-atherosclerotic event, but we have two hypotheses of what could actually be occurring. So as I orient you here to the vessel, we have a true lumen, we have the intima that lines that true lumen, we have the media and the adventitia. There are two hypotheses of SCAD, the outside in and the inside out. The inside out hypothesis is the concept that the pathology of SCAD begins from the inside, that there's an intimal tear that disrupts this endothelial intimal layer, and you get flow of blood from the inside out into the media, creating that filling of blood in the false lumen. Therefore, inside out. However, more recent advances in OCT imaging has shown that it's more likely the outside in hypothesis is what's really occurring. And what that looks like is the development of an intramural hematoma that spontaneously develops in the false lumen, as exhibited here with the gold star. And why is that? The majority of cases actually don't show an intimal tear. Less than 1/3 of cases show an intimal tear. More cases of SCAD show the presence of this intramural hematoma. And at times, there's no tear, and you get compression and occlusion, as you can see here. It's the development of the intramural hematoma and the extension and the compression of the coronary vessel that causes the acute coronary event. And that's why I kept the pathologic as well as the histopathologic slides for you to see, because the development of the false lumen and the compression to the coronary vessel is so impressive. And I wanted you to keep that in your mind. In terms of risk factors and associations, we've all been taught in medical school that pregnancy is the typical associated risk factor of SCAD, but it exists way beyond that. And that's what recent research has shown us. Anywhere from emotional stress to migraine headaches to intense exercise and Valsalva straining still remain precipitating factors, but we have other areas such as the interplay of sex hormones, which are still not widely understood. Is it the changing fluctuations of estrogen and progesterone, as well as the arteriopathies that have been associated, such as FMD that's been previously mentioned? So it's very important to recognize that there's an interplay of key associated factors. Hypertension is an emerging risk factor that's being shown to be associated with SCAD, and the controlling of blood pressure after the incident SCAD effect has been shown to reduce recurrence. I wanted to create a juxtaposition of SCAD and ACS. It's very important to remember that SCAD is not an atherosclerotic event. It's not platelet driven. And when you think about ACS, the SCAD patients typically do not have the same traditional coronary artery disease risk factors. So here, highlighted in red are your typical CAD patients that present with a heart attack. But when you look at patients with SCAD, they're often younger. They have a high predisposition to other arteriopathies, such as FMD, and they bring with them other types of associated factors or precipitating factors, such as emotional stress and physical exercise. Additionally, you see SCAD in a number of non-smokers. And I wanted to bring up the emerging genetics. There's been a gene locus that's been identified that's been associated to both SCAD, FMD, as well as cervical dissections and migraines. It's really important to remember the key association between SCAD and FMD. Remember, it's as high as 60%. And once you make that diagnosis of SCAD, you've got to scan your patient from head to toe. And CT imaging is really gold standard, but if your patient can't tolerate IV contrast, you can always defer to MRA. But it's really important to be aware that these arteriopathies and the classic FMD can be found not only in the renal bed, but also in the femoral beds, as well as present as an iliac dissection. And the cerebrovascular system has also been known to be involved in both tortuosity and aneurysms. You know, the clinical outcomes associated with the finding of these extracoronary abnormalities still needs to be determined, but it's important to make the diagnosis so you can follow your patients prospectively after the diagnosis has been made. So getting back to the SCAD patient, how is she or he, but they're mostly women, how is she going to present? Well, the bottom right is one of my patients that activated STEMI. These patients present as an acute coronary event. And as you can see up top, when you look at the actual presenting symptoms, chest pain is very common, just as you would expect chest pain in a patient with aortic dissection. So that chest pain is real. They often have increased biomarker evidence of myocardial injury because this is an acute coronary event. Expect SD elevations. 2 to 5% will even present with cardiogenic shock, and anywhere from 3 to 11% have presented with arrhythmias as well as sudden cardiac death. And that's why these patients activate the STEMI pager and they're brought to the cath lab. Coronary angiography remains the gold standard for the diagnosis of SCAD. And it's important to recognize that this classification system, the YIPSA classification that's recently been defined, has helped in the recognition of SCAD. Now, will every case read and present like this? Probably not, just like most of medicine, but it's important for you to be aware that there are 3 types of SCAD. First and foremost, don't be afraid to use IC nitro. And if you're an interventionalist, you know you're using it often in acute coronary syndrome to really define your vessel. You want to make sure you're ruling out spasm. Type 1 SCAD is the kind of SCAD where you will actually see a dissection plane. This is the kind of SCAD that you do not want to be putting a wire down the vessel. And this is where you might see multiple lumens. This is where you want to walk away if you can and manage this patient conservatively. Type 2 SCAD is your classic SCAD, where you see the intramural hematoma and narrow compression that's happening. It's very diffuse and it's smooth. Type 3 SCAD is the great mimicker of atherosclerosis, and this is where you might struggle. What you're looking at here are cartoon schematics as well as OCT imaging at the top. It's really important for me to repeat again that the diagnosis of SCAD is often made in the cath lab with the angiogram. The use of intravascular imaging is highly reserved for the cases that are ambiguous, where the diagnosis is in question, and really where you have either a type 2 or a type 3 phenomenon occurring, and you can't decipher or you want to document the presence of an intramural hematoma. In those cases, as I'll show you, there are some techniques you can use to safely get the imaging. When it comes to which imaging, OCT has higher spatial resolution, and that's why that's the preferred imaging strategy when being used in the cath lab. So let's move on to what it's going to look like when you're in the lab. Here you're looking at an angiogram of the LAD vessel, and what you can appreciate is this narrowing right here in the mid-segment. But maybe you're not convinced that this is SCAD. And therefore, let's say you and your experienced operator were deciding between type 2 and type 3. I'm going to show you that these are OCT images of the same vessel. Starting here, this OCT segment corresponds to this area in the vessel, and you can appreciate the presence of intramural hematoma in the false lumen. And that continues in the next frame, and then here in this frame corresponding to about this location where you can see slightly a little bit of contrast staining there, that's your intimal flap. So this was technically a risky vessel to wire because you do have an intimal tear. And here you can see that connection between the true lumen and the false lumen. Again, true lumen and false lumen and the blood causing later compression of the vessel. In terms of another example, sometimes you will be fooled. I mean, SCAD will be fooled, and we've been conditioned to believe that narrowing or stenosis is atherosclerosis. Here you see narrowing, stemming from the ostial LAD, or even you can argue the distal left main, all throughout this proximal segment of the LAD. Maybe you feel it's nothing, but OCT imaging right here, when you see the distal left main coming into the LAD, this is actually the start of intramural hematoma, and then it begins and it extends. And then as you get further down the vessel, you have circumferential presence of intramural hematoma. No significant compression here. It's important to recognize when something is not going to be SCAD so you don't overdiagnose it. And please remember that the presence of intramural thrombus is almost never found in SCAD. So here you see some white arrows actually pointing to the thrombus as well as thrombotic cutoff that's happening in the vessel. This is not SCAD. Similarly, do not be mistaken with coronary vasospasm. So again, this looks like narrowing of this tubular vessel, but after IC nitro, you see that the vessel plumps up. Be aware of that and always pay attention to the distal vessel as well. So in terms of the algorithm for the management of acute SCAD, I've already told you that the management is largely conservative. The patient is clinically stable. That does not mean chest pain free. I'm talking clinically, electrically, and hemodynamically stable, walk away. And it's going to be really hard for the interventionalist to do that, but walk away, especially if the patient is stable and they don't have any high-risk anatomy, such as left main involvement or multi-vessel involvement. The management is largely conservative, which we'll discuss, but it's very important to monitor that patient in-house. Well, what if the patient's stable, but you have high-risk anatomy in the middle, like left main involvement or severe proximal two-vessel dissection? In these cases, think about referring to Cabbage, because the propensity of that patient to progress, then become hemodynamically unstable or electrically unstable, is higher. And you're going to get a better result in terms of revascularization if you go for a Cabbage approach, as opposed to try to attempt PCI, and I'll show you why. And again, remember that if you have active or ongoing ischemia as represented electrically or hemodynamically, that's when you're going to have to consider, is PCI the right option or Cabbage if it's one vessel involvement? But really, Cabbage is going to give you a better result because PCI is often met with a lot of technical failure. In terms of conservative management of your SCAD patient, what does it really look like? Well, one retrospective observational study showed that there's about 1 in 6 chance of a serious early event when the patient is managed conservatively. And largely those patients were ones that had a high degree of stenosis up front, or multivessel involvement, and those cases that had isolated intramural hematoma involvement that didn't have an intimal tear or compression, because the natural history of that in the early stages of that disease process is that it's going to progress to compression. And that's what this study found, that 1 in 6 patients will have deterioration within the first 6 days of presentation. So that's important to keep in mind. And that's really the reason why we advocate for higher in-house observation after the incident event. In terms of why we should be really judicious and when we think about operating and doing an intervention, because just because you see a lesion doesn't mean you can fix it, which is very difficult for interventionalists. And that's because there's a lot of technical failure. First and foremost, when you start, here's an example of multivessel SCAD. You're seeing it in the LAD and the involvement of the diag. And when you actually start stenting in this vessel or even wiring it, what you can get by stenting is hematoma propagation upstream and downstream, and you can lose the vessel and lose flow. Similarly, wiring these vessels, as they are known to be fragile, they're known to be tortuous, and staying within the true lumen is very difficult. You can get abrupt acute vessel closure, and then you're going to be in an emergency situation, usually reaching out to Cabbage. The rate of needing Cabbage bailout in attempted PCI for SCAD is very high. It's been reported as high as 45%. And here's just another complication of a patient who was stented, and then all of a sudden the hematoma resorbs over time and you have stent strut malopposition. This can happen as the hematoma gets absorbed and resolves. In terms of Cabbage, here's an example of a patient who had left main involvement, was referred for Cabbage. What we do see 1 year later is that the grafts close because the vessel heals. And what that ends up helping you with is you bailed yourself out of a difficult situation of left main stenosis. 1 year later, your grafts are going to be closed, but hey, you got yourself out of that hemodynamically unstable situation. Cabbage is a very safe procedure in these patients with good outcomes. In terms of the post-procedural course, once you've had the angiogram completed, you've made your diagnosis, and let's say you're going to manage your patient conservatively, what does it look like? Remember that the goal is to restore flow. So if you have TIMI 3 flow, you're done. Chest pain is expected. So you're going to be managing that patient in-house with pain control, whether anti-anginal, analgesic, or managing their blood pressure. And I've already shown you now why we need in-hospital observation to make sure they don't have extension of the hematoma or reoccurrence. You'll be watching them electrically, hemodynamically. You want to really avoid repeat angiography unless you see one of those compelling hemodynamic or electrical parameters that will push you to go back to the lab. In terms of medical therapy, the presence of LV dysfunction is largely going to guide guideline-directed medical therapy use for heart failure. Beta blockers are the medications that have been found by observational data to reduce the recurrence of SCAD, and treatment of blood pressure afterward has also been key. In terms of systemic anticoagulation, we discontinue them. Once the diagnosis of SCAD is made, there's no data to suggest that even dual antiplatelet therapy isn't necessary. There is some argument that aspirin is helpful, low dose, but a lot of experts would argue that this is not a platelet-driven phenomenon and there's no presence of traumas. Yet the consensus is to use baby aspirin. In terms of statins, we largely limit the use of statins to patients who have otherwise indication based on their cholesterol. In terms of the recurrence of SCAD, the rates can be anywhere from 5 to 15%, very difficult to predict. The factors that predict it are largely remain not understood, but you want to avoid extreme physical and emotional exertion in terms of inciting precipitators. And the recurrence has been associated with uncontrolled high blood pressure, FMD, and migraine headaches. In terms of recommendations for physical activity post-SCAD, what is safe? A lot of patients are heavily restricted in terms of exercise parameters. Their physicians are scared to watch them exercise. And that has led to so much unnecessary weight gain, poor emotional health, and a lot of sedentary lifestyle. And that is not the recommendation. Patients after SCAD should be recommended to cardiac rehab, just like all of our other patients by guidelines for an acute coronary event. Cardiac rehab is essential for addressing their exercise-induced symptoms and providing them with immediate feedback on exercise hemodynamics, and also helping them individualize their care to avoid those extreme high levels of strain and exertion. So we got to recommend our patients to go to cardiac rehab after their SCAD event. Similarly, the big question becomes, can I get pregnant after SCAD? And women have been told for a very long time that they can't get pregnant after SCAD. Mayo Clinic has the largest series of women that had 31 pregnancies in about 22 women after SCAD. And what they found were a majority of them were able to have live births 60% of the time, and only 11% had recurrence of SCAD, which was only 2 in that series. One had it 9 weeks postpartum and the other one years later. Based on that small segment of data, pregnancy appears safe. Nonetheless, if you are going to get pregnant after you've had SCAD, you've got to do it with a very concerted high-risk team in consortium with a cardiologist. And what does that look like? A lot of it looks like functional assessment of your heart function, as well as stress testing before, consideration of early routine prenatal care, as well as cardiac and maternal echoes throughout the pregnancy. It's largely not understood and needs to be managed, but it's an ongoing area of research, and we shouldn't deny our patients if it's their wishes. In closing, I'd just like to emphasize how important SCAD is in terms of the diagnosis. It's a very important cause of acute coronary syndrome in women. It's often under-recognized and misdiagnosed. The treatment is largely conservative. If you have TIMI-3 flow and the patient is electrically and hemodynamically stable, walk away. Remember that PCI is met with a lot of technical failure. It's very challenging, and Cabbage should be used if you have a high-risk case that requires revascularization and restoration of flow. Remember the key association with vascular tortuosity and fibromuscular dysplasia, and to scan your patient head to toe. Remember to manage their blood pressure throughout the hospitalization and afterwards if been associated with recurrence. And remember that the majority of pregnancy-associated SCAD occurs postpartum, and they've been associated with having a much more severe clinical presentation at the time of presentation. Recognition is key. As my father would say to me when I was in med school, the eyes can't see what the mind doesn't know. It's very important to tune in and to be able to recognize SCAD. That's the only way we can begin to treat it properly. Thank you for your time and attention. I look forward to your questions during our live moderator session.